Hi, my name is John McCluskey. I'm one of the senior anesthesiologists here at the Children's Hospital of Philadelphia. One of my areas of expertise in the OR is providing neonatal anesthesia. Today I'm going to speak to you specifically about some of the issues and problems we encounter every day in terms of taking care of our smallest patients in the operating room. In terms of the specific topics of discussion I'm going to address, I will talk about the perioperative care of the surgical neonate, some of the physiologic and pharmacologic considerations we need to discuss or think about when we're taking care of the neonate in the operating room undergoing a surgical procedure. We will talk specifically about what we do in the OR in terms of detailed anesthetic management. One area of concern or controversy in the OR is intraoperative fluid management in the neonatal surgical patient. I will go into more detail of how we figure out or determine what the fluid requirements are for the neonate in the operating room. Here at CHOP, we were several years ago having some issues concerning the intraoperative and actually the perioperative management of the neonate coming to the OR and going back to the NICU. These areas of problems focus specifically on communication, intraoperative fluid management, and temperature maintenance. We also were having significant problems with the babies having bleeding issues in the OR. To address these problems, we created what we call here our neonatal perioperative group. This group is made up of several members of various disciplines, which include neonatology, surgery, nursing, which includes NICU and OR nursing, and respiratory therapy. The objective of the group when we first got together is to improve the overall care of the neonate undergoing surgery. We review cases, especially of anything that's happened in the operating room where we transport a patient from the NICU to the OR or back, in terms of any issues that have come up with a neonatal surgical patient. We set policies and procedures on various situations. For example, performing surgical procedures in the NICU. Sometimes we have patients who are so unstable it's not in their best interest to transport them from the NICU to the operating room to perform a procedure. When that occurs, we have a policy by which we can basically duplicate the surgical environment in the NICU itself. We'll bring us OR nursing team down from the fourth floor with the specific equipment that's needed to perform a surgical procedure. We'll bring an anesthetic machine and the various drugs and supplies that we need, along with an anesthesia tech to help provide the services we need in terms of taking care of a neonatal surgical patient in the NICU itself. We've been very successful with that. We've been able to reduce the morbidities and actually some mortality associated with neonatal surgery with development of this team. A significant issue, which is always in any institution, communication. We were able to develop a perioperative checklist to ensure that most of the issues that are involved with the babies going and coming from the OR would be addressed prior to surgery. These included things such as whether blood's ordered, blood products, who was going to do the procedure in terms of surgeon, who the anesthesiologist was. All this was to be documented on a checklist, and then specifically it's a teal or turquoise blue type of sheet that's easily seen in the record so that people can refer to it without much difficulty. It's made a big difference in terms of communication from the NICU to the OR and back, and specifically attending is attending communication. This picture I show here of a buretrol containing 100 cc's of fluid illustrates some of the problems that we had with fluid management. If I were to drink 100 cc's of fluid, I could barely get my tongue wet. For neonates, 100 cc's, if I administered this to a 1 kilo baby very quickly, they could go into congestive heart failure. So it's imperative that we measure fluids very meticulously in the OR when we're dealing with these very tiny patients. We were also, as I mentioned before, having problems with thermoregulation of the neonate in the OR. To specifically address this issue, we needed to discuss why is the neonate more prone to losing heat in the OR. Well, there are a variety of reasons. One, there's a large surface to body mass ratio. There's a greater percentage of cardiac output that goes to the brain. There's a large head, no hair. Warm blood going to the head, which has a large surface area, allows for a greater dispensation of heat within the environment. And also neonates have a decreased ability to maintain heat. There are 4 thermoregulatory processes by which neonates or anyone loses or gains heat. They involve radiation, conduction, evaporation, convection. We looked at all these specific processes to see what we could do in terms of decreasing the loss of heat for the neonate in the OR. In terms of radiation, it's a very simple matter to decrease heat loss within the OR. Turn the temperature up in the room. Sometimes it's easier said than done, due to the fact that some ORs do not have a fine control in terms of maintaining temperature in the OR. For this reason, and for some of the rooms in OR setting here, we've utilized a radiant warming device to ensure that there is proper heat administered to the baby and that there's a decrement in terms of heat loss from the baby themselves. We improve conduction by warming the operating table in the operating room. This can be done in 2 specific fashions, either one with a warm water blanket or what we call an under baby bear hugger blanket, which uses forced air convection or warm air convection. We also warm the IV fluids in the OR with a fluid warmer. We warm the inhaled gases using a humidifier, and we also provide a chemical warming blanket for transport back and forth from the OR to the NICU. As you can see in this illustration here, here's our typical anesthetic circuit, which has a humidifier incorporated within the circuit itself to provide warm humidified gases. Here is the chemical warming blanket I spoke about several minutes ago, which we use again to transport babies back and forth in the OR in a very effective way to maintain heat or decrease heat loss through conduction. In terms of evaporation, the 3rd process by which you can lose heat, a thermoregulatory process, we make sure that the irrigation fluids used in the surgical sites are warmed. In terms of convection, the 4th process, we made sure that the doors were kept closed in the operating room and that the patient is covered traveling from the NICU to the OR and back. As you can see in this picture here, at CHOP we've created what we have described as the thermal neutral environment within the OR. Because of all the different processes involved in terms of maintaining heat or losing heat, by utilizing the humidified circuit at the bottom of the picture, the under baby bear hugger, and the overhead radiant warming lights, we're able to maintain the temperature of the baby very easily now within the operating room. And we are so good at it that sometimes we need to turn off some of this equipment because the baby is becoming too warm. As I mentioned to you before, this group had discussed some issues we were having with intraoperative fluid management. In terms of the maintenance fluids, we decided that there would be dextrose-containing solution with half normal saline in it, and that would be started at maintenance rate, and that would be started in the NICU and brought to the OR. We also decided that we would check dextrose sticks or Accuchecks Q1 half hour to 1 hour within the operating room, since we were having significant problems with hyperglycemia due to the stress of surgery. We also discussed specifically what we were going to use in terms of 3rd space fluid losses in the OR. We decided that we would put our maintenance and deficit fluids on IV infusions in the OR so that there would not be an over-administration of fluids to the babies. In terms of issues with hypotension in the OR, we made sure that we had bolus syringes made up specifically at 10 cc's per kilo of normal saline for those brief periods of hypotension that we encounter with these babies in the OR. We also discussed as a group that when we reached fluid resuscitation in terms of 100 cc's per kilo, we would consider using a vasopressor or vasoactive agent to maintain blood pressure, specifically dopamine. As I had mentioned before, we were having problems with coagulation issues with the babies in the OR, specifically the babies who had necrotizing enterocolitis and were coming back to the OR for either exploratory laparotomies or reanastomosis of the bowel. A good portion of these babies were on TPN in terms of nutrition, and they were having problems with liver dysfunction secondary to TPN and their history of necrotizing enterocolitis. And we're having, as I've mentioned to you before, problems with bleeding in the OR, so we decided as a group that any of these babies coming to the OR would have to have FFP, fresh frozen plasma, or platelets ordered as a routine to decrease the problems we were having with bleeding in the OR. I would now like to speak specifically in terms of some of the physiologic and pharmacologic considerations we encounter every day in the OR as anesthesiologists when we take care of neonates. These physiologic considerations include a number of organ systems, which include cardiovascular, respiratory, neurologic, renal, and hematologic. So I asked all my trainees and a number of people who I encounter who take care of neonates. What is the number one physiologic difference between neonates and adults? Neonates grow, adults shouldn't grow. The neonate will triple their body weight in the first year of life and double their length. Growing takes a lot of calories. The normal adult usually needs 30 cc's per kilo per day in terms of basal metabolic needs. However, babies can need, and depending on their prematurity, they can require 100 to 150 kcals per kilo per day just for normal growth. They have a high metabolic rate because they're growing, laying down new bone, tissue, having a great deal of energy expenditure. For that reason, heart rate and respiratory rate have to be equal. Respiratory function and cardiovascular function have to be equal. VQ equals 1. In all of the physiologic systems involved with babies, there is less reserve as compared to adults. Specifically the heart, there's less inotropy. If you stress the heart and the neonate, they do not have the capability to increase the forward flow of blood out of the heart. Cardiac output in the neonate is dependent upon heart rate. The stroke volume is fixed. Thus, bradycardia is not tolerated well in the neonate because it specifically drops cardiac output dramatically.